Welcome to Limmer Education's National Registry Review. My name is Dan Limmer from Limmer Education. I'll just quickly introduce myself. I'm a co-founder of Limmer Education, really been more than 10 years now. I've been a paramedic for 40 years, involved in EMS for 44, and I've had the good fortune to write several books in the EMS field, including my emergency care. That's the yellow EMT textbook. My job here is to help you through to help you pass the National Registry. And I'm going to just quickly give you my philosophy and the three things I'm going to do in this 2-hour session. The first is to review content. I think there's certain core things you need to know. I've strategically chosen questions that we're going to go over here and do some readiness assessment exercises to make sure you know those things. I'm also going to teach you how to read, how to interpret, and ultimately how to choose the correct answer in a National Registry style question. And then at the end, the third thing I think is really important in my philosophy is mojo. I believe when you complete this session that you will have a better feeling of being able to pass the National Registry exam, because that's ultimately what it's all about. It's the ticket you need to go out and do what you have been passionately studying for. So in this video, here's a little roadmap of the things we're going to do. We're going to talk about some steps in evaluating a question. Then we're going to do some general practice questions. Some frequently asked questions about the National Registry. I know you have questions, and I've put together some of the more common ones here for you. And then we're going to talk about what you see and what it means. We're going to take a question and we're going to break it down into the individual parts, what each part of that question, what you see, and then what it means, how you interpret or value what's in the question, how to read it properly. It's very important. So we'll do some more practice questions. We'll talk about general path to success. And then we have a readiness assessment test. There's 12 questions. This was actually research I performed. My theory was, how can we do a small quiz that will help predict whether someone will pass the National Registry? Now, I'll describe it more then, but these are conceptual questions. It's looking for your gut, looking for a test of your knowledge to assess if you're ready for the National Registry. We'll discuss multiple response questions, sometimes called TEI questions. You're going to see those on all of the National Registry exams now. I don't want them to throw you. They're certainly a different style. We're going to go over them. And then finally, how to use practice tests. Most times people just start flying through questions. I want you to do it right, and I'm going to tell you how. So let's get into it. When you evaluate a National Registry style question, there's a few things I want you to look for. Now, this is for really any clinically oriented question, right? There's 5 sections on the National Registry, right? We have airway, ventilation, respiration is one. We have medical emergencies and OB, cardiology and resuscitation, that includes stroke material. We have trauma emergencies and operations. So for those first 4, any of the clinical things, this is just a start of some of the things I want you to look for. Think about the patient's mental status. There's probably very few more important clinical signs, if any. So if the question says the patient's alert or confused or unresponsive, it's easy. But it doesn't always say that. National Registry questions, don't use a lot of words. But if the patient complains of something, well, we can believe at that point that the patient is able to respond to questions and most likely alert and has a relatively normal mental status. Anyone that doesn't have a normal mental status is something that we have to be concerned about. Now, there's other things we should look for in part 2 are signs of criticality. Now, this is written. Now, if you look at a patient, that's one thing, but now you're reading about it. So individual words make a difference. Things that describe respiratory failure like sleepy, tired, gasping, shallow, right? Those are things, especially when you combine them with an altered mental status, it's looking like we should probably ventilate the patient, right, with a BVM. And those things indicate criticality. So not only do they say, gee, maybe you should ventilate. This is a really commonly missed thing. But it also means that you would be looking to expedite as well. Now, when we're talking about expediting the patient complaint, determining the patient complaint, that's important as well. If we have an MI, if we have a stroke, if we have serious trauma, those are time sensitive. There's things that we're going to try and get to an appropriate facility as quickly as we can. Others have treatments. For example, aspirin being a priority in patients with suspected cardiac chest pain. And a diabetic patient that's responsive enough to take oral glucose is something that we can treat on the scene because we can fix that. And finally, let's look at vital signs. Vital signs are important, but a lot of times they're not the smoking gun that's going to say, oh yeah, that really does it. Now, there are some things like we take an altered mental status and a trauma with a narrowed pulse pressure, tachycardia. There's certain things that are important in vital signs. Maybe you have indications of intracranial pressure and herniation, where we have a decreased pulse and increased blood pressure. But these are some of the primary things I want you to look for when you evaluate a national registry question. Any clinical question, these are important things to think about. So let's get into some questions. I picked 3 questions, and I picked trauma questions. Now here's how we're going to do this. I'm going to put the question on the screen, and feel free to hit pause on your video. I'm going to take a little bit of a pause, then I'm going to read the question. But I'd like you to read it without having me read it to you, because that's how the exam is going to be. So hit pause, look at the question, read it twice before you even look at the choices. I'm going to go through and talk about some of the things that are important. And because people generally like trauma, I've chosen some trauma questions to open up this session. A 74-year-old male complains of upper back pain and difficulty breathing after a fall. He has pain and crepitus to the right side of his back below his scapula. He has equal chest wall expansion, and his breath sounds are diminished in the affected area. He has a pulse of 82, respiratory rate of 18, blood pressure 142 on 92. He's satting at 96% on room air. You should suspect A. All right, let's go through this and figure out what's important, okay? I always like to look at the age, right? He's 74 years old, and he has upper back pain and difficulty breathing after a fall, so it's trauma. So he has pain and crepitus to the right side of his back below his scapula. But the fact that he has equal chest wall expansion is significant, and breath sounds are diminished in the affected area. Now, a pulse rate of 82, respiratory rate of 18, and that blood pressure, even decent sats, for someone who's 74, doesn't say to me it's critical. This is kind of the way I'd like you to look at the question. Not only to read the words, but to value the important things, right? And I'll underline difficulty breathing here too, even though it's really part of the complaint. So now that we've looked at this more carefully, let's look at the choices. Flail segment, tension pneumothorax, or cardiac tamponade. All right, so one of the ways to do a question is to figure out what we can rule out, all right? Now, a flail segment's a pretty serious injury, all right? And remember we saw that he has equal chest wall expansion, right? There's no paradoxical motion, no flail segment, so I'm going to get rid of this flail segment. Now, the other thing I'm going to get rid of in here, and there's probably 3 that we should be able to pretty easily get rid of, and one of those is tension pneumothorax. Tension pneumothorax is not the case because he complains of upper back pain, so he's talking to you. His vital signs are pretty good. He's not hypotensive. Remember, tension pneumothorax is an issue involving reduced preload, pressure in the chest, and hypotension, all right? And his lung sounds are only diminished in the affected area. And in a tension pneumo, you'd say, yeah, there's got to be more there. So now I'm going to look at this and say, now I've got pneumothorax and tamponade. Now, if I have cardiac tamponade and my breath sounds now are diminished, All right, that's not a heart thing for one. The other part is that this is to the right side of his back. Not that that totally rules out the heart, but this is a lung thing. It's not a heart thing. So let's rule out tamponade. What's the correct answer? Pneumothorax. Why is that the correct answer? Because he fell. The crepitus means he probably broke a rib. And from that, he gave himself a pneumothorax. Now just take a second to reflect on this question. Do you look at your National Registry style questions with this significance? Now, this didn't take all that long. Read the question, figure out what's important, and then use that to go through and either rule out or rule in conditions before you finally make your decision. National Registry questions don't have a lot of fluff in them. And you can see we underlined a lot of stuff here that I think was probably significant. If you can identify the right things, you can in fact get the question correct. I hope you did well on that. Now let's use what we learned here to go into the next question. A 24-year-old female complains of chest pain and difficulty breathing. She tells you a horse kicked her in the chest. Okay, that's not good. Her skin is pale and diaphoretic. There is a contusion to the left side of her anterior chest wall. Breath sounds are absent over her left lower lung. Vital signs, pulse of 116, respiratory rate of 22. Blood pressure is 92/80, and she's satting 95% on room air. You should suspect. Now I did this so we can build on what we learned last time. There's a lot of material in this question, and before we even look at the choices, let's go through and figure out what we have. So now we have a 24-year-old female. Unlike the 74-year-old female, short of any medical problem, she'll probably be able to respond better to trauma and compensate. And not surprisingly, after being kicked by a horse, she has chest pain and difficulty breathing. Her skin is pale and diaphoretic. Okay, shock. We're looking at, even if you didn't look at the blood pressure later, that pale diaphoretic skin is a pretty ominous sign. All right, so a contusion. All right, she got a bruise on the left side of her anterior chest wall, and breath sounds are absent over her left lower lung. Now, this vital signs pattern is a little bit different than the one before. She's tachycardic at 116, her respiratory rate is rapid, and not only is her blood pressure questionable, the pulse pressure, the difference between the systolic and the diastolic is only 12, and it should be a lot higher than that, so she has a narrowed pulse pressure, and this confirms what we thought about as far as shock goes. Nonetheless, she's sitting at 95% on room air. You should suspect. All right, so now we're going to go back and use the same process we did last time and see what we can rule in and what we can rule out, okay? So in this, we have a contusion, but we still don't have any paradoxical motion. Flail chest is a pretty serious thing. I would imagine a solid kick from a horse really could do that. But in this, she's sitting at 95%. She's still moving air. There's no indication of fracture or anything else. So I'm going to say I don't think flail chest is the issue. And while we have signs of increasing shock, the absent breath sounds over the left lower lung and the fact that she's complaining of something, could she develop a tension pneumothorax later? Yeah, but I don't think that's really the case. So now we have the difference between hemothorax and pneumothorax. So what's going to help us figure out between those two? Well, a pneumothorax that doesn't progress to a tension pneumothorax usually doesn't cause hemodynamic instability, changes in blood pressure and narrowed pulse pressure and skin. Now, the other thing that happens is that pneumothorax, although not always, many times the air goes to the apices or the top of the lungs with the pneumothorax. But with the hemothorax, blood is going to go towards the bottom. It's going to go down. So because we have what looks like shock and we have lower breath sounds that are absent, I'm going to get rid of pneumothorax and I'm going to say hemothorax. She's got blood in there that's causing shock, and the blood is going to go to the lower lung here, and that's it. So do you see where this all comes together? Right? Difficulty breathing, pale and diaphoretic, chest trauma, lower lung says hemothorax. No flail segments. She's still responsive, and while she's starting to be shocky here, trying to compensate, tension pneumothorax isn't happening yet. And the pneumothorax doesn't create this hemodynamic instability. So I hope that as you go through these questions, we're looking at how everything is important. I'm going to do one more question. We'll have lots more questions as we go on through this video. A 5-year-old female fell off her skateboard and cut her upper arm. Her mother is holding a blood-soaked sweatshirt over the wound. When you examine the wound, you see a 5-inch laceration that is spraying blood. You should immediately. All right. Even though you look at this, okay, what should I do? Let's still go back and just make sure that we look at and we value this stuff in the question appropriately. So she's a pediatric patient, and they can compensate a lot, right? And she cut her upper arm, and it's a big one, right? 5-inch laceration, and it's spraying blood. Now, mom, took off her sweatshirt, and she's holding the sweatshirt over the wound. You should immediately. All right. We know there's some things in bleeding control that we don't do. We don't do arterial pressure points, and we don't elevate as the thing we should do immediately. And that gives us two choices in our bleeding control toolbox. One of those is to apply direct pressure. The other is to apply a tourniquet 2 inches above the laceration. And you're thinking, well, mom's holding a blood-soaked sweatshirt over the wound. The question you should ask yourself is that pressure? And is it being done well? Because it's still spraying blood. So what's the first step in bleeding control? The first step in bleeding control is to apply direct pressure. Now, I'm not saying you have to do it for a long time, but that's the answer here. It doesn't say mom is putting pressure on it. She's holding a blood-soaked sweatshirt over the wound. If there's a gusher in there, you see arterial, you could take your gloved hand and put it right in the wound and stop that bleeding. Your direct pressure is going to be different, and it's going to be efficient, and many times will stop the bleeding. Should your initial efforts not stop the bleeding, yes, you can go to a tourniquet if it's appropriate. But the other thing I'll say is apply a tourniquet 2 inches above the laceration. Well, that's okay, but we're talking about her upper arm. I'm not sure how much space you're going to have on there, where it is in the upper arm. Obviously, we do tourniquets high and tight. This 2 inches above the laceration is kind of the old thinking where you put tourniquets, right? High and tight is the best answer when we're talking a tourniquet. So in this case, the first thing we are going to do when we get there is we're going to apply direct pressure. Remember, you're saying, but it's a spurting wound and mom's already tried. Well, no, she hasn't. She's held a sweatshirt over it, and that sweatshirt will not apply the pressure that's required. Sometimes we put pressure over a bigger area. Other times, like I said, we go right in that wound and we find the bleeder and we put our fingers on it. That's what direct pressure is, and that's what we should do here. This was kind of a warm-up. These 3 questions got you through. I want you thinking about questions, how deeply you need to read them. And when we get into the what you see, what it means section, we're going to do this type of analysis in even greater depth. Break these questions down into parts so you can make the right determinations. So taking a little break from questions, let's talk about some of those frequently asked questions. And I'm going to give you, interestingly, the same answer to all these questions. One of the most common questions we get is, what does the number of questions mean on the National Registry? What if I get 70? Or what if I get 110 or 120? Now, my advice for you, when you're sitting at the computer and you're taking the question, is keep calm and answer the question. If you're wondering about how you're doing and getting anxious because of the number of test questions that are going on, maybe you've tried the National Registry before, answer each question to the best of your ability and move on. It doesn't matter if it's question 69 going to 70 or 110 going to 111. The single best thing you can do is stay calm, answer the question, keep your head about you. It is that important. Now, the other thing I hear people ask about, well, what happens if I see a lot of the same question? Well, first of all, the National Registry makes subtle changes in questions. Sometimes it's a one-word difference that goes between respiratory distress and failure, or there's different types of things they're asking. What do? Keep calm, answer the question, right? Remember that of the 70 questions minimum that you get on the National Registry EMT exam, 10 of those questions are going to be pilot questions. They don't count towards your score. So if the National Registry decides to give you 7 of those 10 questions as OB, or 7 of 10 on chest trauma, like we just talked about, don't think it means that you got prior questions wrong and you should change your answer because of that. What do? Keep calm, answer the question. If you lose your head worrying about things that don't involve the question in front of you, you're going to lose focus, you're going to waste time. Now, what happens if you see a lot of questions that you think are really difficult? Maybe they're unusual, or there's words or diseases you haven't heard. They look like they're really hard questions. Well, keep calm, answer the questions to the best of your ability, right? The fact that you're seeing these difficult and unusual questions may mean that you're doing well. Remember, the exam is adaptive. It starts with easier questions, and it gradually gives you more difficult questions. So if you're getting questions like that and you're freaking out because you don't know what some condition happens to be, it may actually mean that things are going well. And just because there's a word in a question that throws you, that doesn't mean you can't read the rest of the question and still figure out some of those things we talked about in the beginning of this presentation. Their mental status, if it's critical, if we need to ventilate, right? We sometimes focus on the things we don't know rather than saying, what can I pull out of this question that's going to help me get this right, and not just throw up my hands. What do? We keep calm and we answer the question. Now, the last thing is, what happens if I freak out about time? Well, you probably suspect that I'm going to say, keep calm and just keep answering the questions to the best of your ability. The National Registry gives you 1 minute per question. The average length of time a person takes on a question is just a little over 30 seconds. Now, not every question is going to be really challenging. You're going to go through and you're going to look at that and say, oh, I know that, especially in the beginning. As they get more challenging, I recommend, I did this myself recently, read the question, read it again, and then look at the choices. Now, you say, well, that takes too much time. Yeah, but if you get the question correct and you get more questions correct, maybe you'll only need 70 questions. Right? This is a don't throw the baby out with the bathwater kind of thing. Answer each question to the best of your ability. Don't agonize over it. Don't second guess yourself. Read the question once, read it again. Do like I did in the 3 questions you saw just before this. And then take your best. I don't want to say guess. I'd like to think you're going to know the answer. But there's 2 ways to get a question right. Know the answer, or know 3 of them aren't the answer. Regardless of what you do, You have time to answer each question well. As a matter of fact, I believe that it's an investment for you because you may get more questions correct and need less time in the long run. All right, let's go on to the next section. One of the most common comments from students who take our review classes is, I didn't realize that you had to read the questions as deeply as you do. And you do. When you sit down for the National Registry exam, you are nervous. There's a lot riding on it, but there is a particular way that you need to read these questions to get all the information you need out of them. So this section is called What You See, What Does It Mean? So the concept is read the question. What do you see in the question? And then what does it mean? The what does it mean part is the part that we miss. It's assigning a value. What does the statement, what does that sign or symptom or vital sign mean to the patient in that particular scenario? Now, sometimes you'll have longer questions, sometimes you have short questions. National Registry questions put everything in there for a reason. And that's what we're going to do in this section. Let's take a look at this. What you see, what it means. A 68-year-old male was stabbed in the chest with a knife. You observe a half-inch laceration lateral to the sternum at the third intercostal space. You do not see any active bleeding, and his neck veins are distended. His lungs are clear to auscultation. His vital signs are pulse of 128, respiratory rate of 34, blood pressure 80/72, and the saturation is unobtainable. You should suspect. Now just take this question for a second and look at it. There's no way that you can read that question just once and get everything you need to know out of it. There are times you have to read the question twice, and you have time for that. So let's break down things that could be important in this question. Well, the person's 68 years old, right? Certainly going to respond differently than someone who's 18 or 28. He was stabbed in the chest with a knife. All right, now that's more than ouch, which might be what you first think. There's a lot of stuff in the chest, a lot of stuff that needs to stay inflated, and a lot of stuff that can bleed profusely. So we have a laceration lateral to the sternum at the third intercostal space. His neck veins are distended. And I'll also say you're not seeing any active bleeding. That might be something too. His lungs are clear to auscultation. All right, that's important. And of course, we have vital signs in there. It's tachycardic, tachypneic. Blood pressure is low with a very narrow pulse pressure. You should suspect. All right, so now let's figure out what all these things mean, okay? He's 68. He might not be able to compensate as well as a younger person. I'm not saying by any stretch of the imagination that a 68-year-old is old. However, like I said before, the existence of coexisting conditions, diabetes, prior heart attacks or heart failure, hypertension, all these things can come into play. He was stabbed in the chest with a knife, all right? Well, not only, like I said originally, there's a lot of bad stuff that can happen inside the chest just because of the amount of vasculature and organs like the lungs, which need to stay inflated. But stab wounds to the chest are a leading cause of cardiac tamponade. Lateral to the sternum in the third intercostal space. Yeah, heart, great vessels, makes me a little concerned about that. Neck veins are distended. Now, this might be one of the bigger clues, the fact that the neck veins are distended, right? Now, when the neck veins are distended, it means blood isn't able to come back from the head and get back into the chest, right? Something is blocking that, so we're looking probably at obstructive shock. Now, the lungs are clear to auscultation. Means it's not tension pneumo. If you think about traumatic obstructive shock, you're looking at tension pneumothorax and cardiac tamponade as being the big culprits with a stab wound to the chest. And you should suspect. It says, what do you think it should be? So to me, I'm thinking, cardiac tamponade. Now, we've done all this without even looking at the choices. Don't fly through questions like this just to get to look at the choices. Understand what you have before you get to the choices. We don't even know if cardiac tamponade is going to be one of the choices, but that's what you'd suspect from this scenario. So the choices are hemothorax, hypovolemic shock, tension pneumothorax, or obstructive shock. All right, so we've already said it's not tension because the lung sounds are clear. So we're going to rule out C. And the hemothorax and hypovolemic shock. Well, hemothorax involves bleeding, hypovolemic shock. Both of those would not have distended neck veins. And that leaves obstructive shock. And we already thought about obstructive shock even before we thought of tamponade because of the distended neck veins. And then once we found the clear lung sounds, we had a better idea of what it was. Obstructive shock is the correct answer. So here's a couple things. Do you read questions this deeply when you practice for the National Registry? Do you read questions this deeply if you've been to the National Registry and give it this much thought? Now remember, there are two ways to get a question correct. One is to know the correct answer. In this case, we could have done that. But if we paid attention, pathophysiology is so important. Those distended neck veins, hypovolemic shock and hemothorax, were bleeding out. They're going to be flat if they're anything. So we know it's not tension. We know it's a hypovolemic shock. We know it's not hemothorax. So obstructive shock is the answer. Either way, you get that question correct. All right, let's go to the next one. Non-responsive 2-year-old female has burnt skin on her left hand and left knee. Her father tells you he heard a loud noise and found her this way. She has irregular, slow, shallow respirations and a rapid carotid pulse. You should first. Whoa. All right, shorter question, but there's a lot of important information in here. And I think, you should be reading this now. You should be thinking, all right, what's going on? What's important in here? Well, she's 2 years old and she has burns on her left hand and left knee. There was a loud noise and she has irregular, slow, shallow respirations and a rapid carotid pulse. You should first. Well, as we do this, if we look at what's important, the fact that she's 2, her vital signs are going to be different than an adult. And we also know that there's certain types of injuries that little kids can get involved in. Burnt skin to the left hand and knee. Now, you may or may not have figured this out. And I think you can get this question without figuring it out. But it's probably an electrical burn. She grabbed something or stuck something in an electric outlet, and electricity went through her and out her knee because that was the part that was touching the ground. That loud noise was probably the sound either of the electric, perhaps her falling. The irregular, slow, and shallow respirations. All right, irregular, slow, and shallow. Right, they point to the need for ventilation. Remember, you need both adequate rate and adequate depth to not be in respiratory failure. You have to have both. These are irregular, but they're slow and they're shallow, right? You see words like that. That means we need to ventilate the patient. And the rapid carotid pulse means it's rapid for that patient. A 2-year-old is going to have a faster pulse than a 22-year-old or a 62-year-old. But when it says rapid, it's rapid for that patient. And then don't forget, don't just go through all the patient information, and don't forget the you should first, right? That wants you to figure out what the priority is. But now that we've gone through this, I think we'll probably have an idea what the answer is when we see the question. I don't think this is the most difficult question that you're ever going to see. But the unresponsive 2-year-old female has burnt skin on her left hand and left knee. Her father tells you he heard a loud noise and found her this way. She has irregular, slow, shallow respirations and a rapid carotid pulse. You should first. Well, we said she needs ventilation. That's choice A, right? So assessing her vital signs isn't going to do anything. She's not breathing. She's in respiratory failure here. And oxygen's not going to do anything because she needs to be ventilated. So what happens if you value that irregular, slow, shallow respirations and said that's a really important part of this question? You're going to say, yeah, I need to ventilate her. And that's what it's about. All right, let's do some more. I got some more of these. 7-year-old male was struck in his left chest with a baseball bat. Ouch. He complains of pain to the area, and you observe a large red mark. He has equal chest wall expansion, and his neck veins are flat. You auscultate rales on the left side of his chest. You should suspect. I'm just going to give you a second now, and if you want to take longer anytime, you can always hit pause and go through and do the exercise that I'm going to do. What in this question is important? So we have a 7-year-old male, and he was struck in his left chest. Not that any part of the chest is more important than the other, but the left chest, right? And he has pain to the area and a large red mark. But he has equal chest wall expansion. His neck veins are flat, and you auscultate rales on the left side of his chest. You should suspect, right? Always figure out what the question is asking. Don't just fly through and then say, okay, I read all the stuff and go on to the choices. In doing this, we need to figure out what the question is really asking, what you do first, right? What you suspect. So if we go through and we break these down, he's 7, all right? We talked about differences in pediatric populations. One of the biggest differences in the pediatric populations, and you can see struck in the left chest, I'll put up here as well, is that kids are, I wish I knew who told me this, kids are bendy, okay? And that means that kids can have significant damage to their thorax, through the chest cavity, and not have broken ribs. Me, I get hit with a baseball bat in the chest, it's going to break some ribs. It's going to be ugly. But kids where the cartilage is still forming and haven't had all that age of the bones, you can do some serious damage without any injury that's visible from the outside. Kids are bendy. There can be damage to the inside without damage to the outside. The pain in the large red mark kind of goes with this theory here that he took a heck of a shot, right? That pain in large red mark. He got hit in the chest with a baseball bat. He has equal chest wall expansion. Okay, not everything is bad. The registry will give you certain things so you can judge where things are. He seems that his lungs are inflating. And he complains of pain to the area. So he's talking to you. We're not thinking that this is, the fact that he's talking to you and he can complain of something is important. And that he has equal chest wall expansion seems like it's telling us that the lungs are okay. Now, his neck veins are flat. That means, unlike the last question, it doesn't appear that there's an obstructive mechanism here, right? He probably doesn't have a tension pneumothorax or cardiac tamponade. So to that end, that tells us something. Doesn't mean there can't be significant trauma because of the bendy kid thing, right? But there's rales on the left side of the chest. Well, there's some kind of fluid there, but it's only on one side, okay? And you should suspect, I want you to say, all right, based on all this stuff, what condition does the patient have? Now, I think this question is an amazing question. And when you see the choices, you're going to see how everything here makes a difference. Okay. So here are our choices: cardiac tamponade and tension pneumothorax. Okay. Flat neck veins make us think, yeah, not so much for those. So we're going to scratch A and B. Then we have pulmonary contusion and we have congestive heart failure. Now, if you're a person who read this superficially and said, "Ooh, rails, that's fluid in the lungs, this is congestive heart failure," you would have chosen the wrong answer, right? For two reasons. One is that it's only on one side, right? Heart failure would be present on both sides, most likely. The other reason is he's 7. And the chance of having congestive heart failure when you're 7 is pretty slim. However, getting hit in the bat, fluid in the lungs, we're not talking about hemothorax, pulmonary contusion, we're bruising lung tissue after getting hit with a bat with that big old red mark on his chest. Pulmonary contusion is the answer. All the information you need is in the question. You have to read, take the time, reason it out, and make it happen. Okay. Next, an unresponsive 4-month-old female is lying limp in her father's arms. He tells you that she was having an asthma attack, but is better now. Her conjunctiva are pale and moist. You're only able to auscultate faint wheezes in her upper chest. Her vital signs are a pulse of 76 and a respiratory rate of 18. You should first. Whoa. Well, let's break this down. I'd ask you now, as we go through these things, all the stuff we're doing here today really is not just for the National Registry. All these things are very appropriate in the field. Anyone who's told you the National Registry is all voodoo and trying to trick you and everything else is not really telling the truth. People get angry because the registry is challenging. Sometimes people don't pass. But if I was given this patient presentation in the field, it means something. All right. So the patient is a 4-month-old female. All right. That's pretty little. And she's limp. Not good at all, right? She was having an asthma attack, but Dad said she's better now. Her conjunctiva are pale and moist, and you are only able to auscultate faint wheezes in her upper chest. Her vital signs are pulse of 76. And then, of course, we're left with you should first. So let's break this down. So she's 4 months old. That's the infant age group. Her vital signs are going to be much different. And according to the Heart Association, some of the things that we will do will be dramatically different. That the baby is limp. And that's a very bad sign. You may recall the pediatric assessment triangle. One is appearance, A, right? And this fails the appearance test, okay? That this baby is limp, not hanging on to dad, scared of strangers or anything else. It's just 4 months old. But really, limp is very, very bad. And the other parts of the pediatric assessment triangle are work of breathing is B, and C is circulation to the skin. We'll talk about that in a second. Right, the asthma attack. Right, that gives you a clue to her history and possibly some of the expected findings. The fact that Dad says she's better now is really a test in there to see if you know that Dad is kind of wishful thinking. Now, the National Registry will never mislead you. They will never tell you wrong information, but Dad can tell you wrong information. The baby may have been struggling to breathe and crying, and Dad says, oh, she's finally going to sleep and she's better, but she's not. So you need to look at this. Again, everything is what you value. Lying limp versus better now. You've got to pick what's the most important. The pale conjunctiva say poor circulation, although moist, says she might not be dehydrated. And faint wheezes in the upper chest say that they are only faint wheezes. Why are there only faint wheezes in the upper chest? Because that's as far as air is getting in. Now, 4-year-old chests are really pretty small. You flip your stethoscope over to the pediatric side and you listen, and you hear a little bit of noise up near the apex, but down near the bases, it's quiet. Quiet's a bad thing. It's a really bad thing. So those faint wheezes means she's not moving air. And validating that even more is the pulse of 76, which is a relative bradycardia for the age group. And you may say, well, bradycardia is below 60, and not for a 4-month-old, right? A 4-month-old, a pulse below 100, you would ventilate. And a respiratory rate of 18, even that is slow for this particular age group. So I think, if anything, if you've read this, whether you broke it down or just were able to, through the force or some type of amazing putting together the question, you say, oh, yeah, this is a really, really sick kid. Our choices now are assess her oxygen saturation level, assist her ventilation with a BVM, administer oxygen by non-rebreather mask, or assist with the administration of her nebulized albuterol. Now, she may have that, being a 4-month-old with asthma. She may have it pretty bad. The problem being is lying limp and only able to auscultate faint wheezes in her upper chest with that slow respiratory rate. Administering oxygen by non-rebreather or assisting with the administration of nebulized albuterol will not work. Those things do not ventilate her, and none of that oxygen or albuterol will get into her chest. It won't get into her lungs, and it won't help her because she's not breathing enough. Now, assess her oxygen saturation level. Choice A, she's limp with pale conjunctiva, and she's not breathing particularly well. You can guess her oxygen saturation is probably in the crapper. And you know what? Trying to figure out how to do that, depending on your PEDS kit and how things happen, be able to get a pulse ox, taped on her finger or whatever, she's in bad shape. What does she need right now? She needs to be ventilated. More than anything, she needs to be ventilated. Now, with asthma, we do eventually want to get the albuterol in there. We have to get ventilations in there first. And that is the correct answer here. All right, number next. A 17-year-old male passed out while playing soccer. When you arrive, he's conscious and tells you he had dizziness and sharp chest pain before he passed out. He points to his mid-sternum when you ask him the location of the pain. He denies any pain currently. His vital signs are pulse of 66, respiratory rate of 18, blood pressure 114 on 72, saturation is 95% on room air. You should. All right, let's break it down. Remember, you can always pause this, and before I show you what I think is important, you can pick out what you think is important, and then say play again, and we'll go into it. So he's 17, and he passed out. Well, that's bad. Now, he was active playing soccer, but when you arrive, he's conscious, but he had dizziness and sharp chest pain before he passed out. Points to his mid-sternum when you ask him the location of the pain. He denies any pain currently. And his vital signs right now are awesome. I wish I had those vital signs right now. You should. All right, let's break it down. He's a relatively healthy, active 17-year-old, and he's going to be more adult than pediatric when this goes. And like I said, his vital signs really look pretty good all in all, that he passed out. And that talks about the potential severity of the incident. He might look good now, but he obviously had dizziness, chest pain, and passed out. That dizziness to me probably means that he had poor perfusion to the brain. Okay. And sharp chest pain, and that's significant in any patient. Now, vital signs, he seems back to normal right now. All right. So, if I were to look at this, I'd say, I'm guessing this kid probably had what's called SVT, supraventricular tachycardia. He had a run of a very, very rapid heart rate, so rapid that it reduced his cardiac output. That can give you chest pain. It'll give you dizziness because it's not pumping blood to the brain, and he passed out. Well, the one thing about young bodies, young healthy bodies, sometimes that passing out resets them. It seems like that's the case now because he does seem to be back to normal. So our choices are transport him in a position of comfort, administer oxygen by nasal cannula, administer oxygen by non-rebreather mask, or transport him fully immobilized to a long backboard. All right. In this question, let me just show you the answer. I can go through and talk about these. But just remember that not every call, not every patient has to have something done. This kid had something happen. He's better now. And the saturation and the fact that his vital signs are so good, I don't think I'd put him on oxygen. And there's no indication that there's trauma. And even if there were, we don't fully immobilize people to a long backboard anyways. We use spinal motion restriction. So if you look at choice A and say, oh, gee, I'm not really doing anything, he doesn't need anything. You'd want to monitor him carefully, but transport him in a position of comfort. This is something that he should be seen at the hospital and then by his physician and maybe even a cardiologist. But right now, we're driving him and keeping him comfortable and monitoring him. That's what it is. All right. I hope that you're enjoying these, and I hope that you're remembering what I said when we started this. If you found that you didn't read questions in this depth, this may be the single biggest thing that you need to pass the National Registry. Even if you don't have a clue on the question, you may read the question and look at the choices, and you may have no idea. But if you use what's written in the question to go back and rule out even a couple of the choices, your odds of getting that question correct have picked up dramatically. So never give up on a question. Read it again, look at the choices, look at the material in the question, use that to rule out some of the choices, and then pick your answer, right? Let's take a look. 70-year-old female who was the unrestrained driver in a car crash complains of difficulty breathing. She has a history of asthma and a pacemaker implanted. You auscultate diminished lung sounds and bowel sounds in her left base. Her vital signs are pulse of 70, respiratory rate of 22, blood pressure is 138/74, and she's saturating 96% on room air. You should. All right. Well, let's take a look. She's 70 years old, and she was an unrestrained driver. Now, remember how I said kids are bendy? The 7-year-old who got the 7-year-old boy who got hit with the bat. 70-year-old people are not bendy. That this unrestrained driver, no less, meaning no seatbelt, in a car crash complains of difficulty breathing. No surprise there. Now, she has a history of asthma and she has a pacemaker. Okay. So history is one thing. Now, history doesn't guarantee something's wrong. And she has diminished lung sounds. You're thinking, okay. And bowel sounds in her left base. We give her vital signs. Vital signs, surprisingly, don't seem as bad as I might suspect right now. And of course, we ask, you should. So let's break it down. She's 70. Now she's geriatric and she'll have issues with trauma and compensation. And she has some coexisting conditions, right? She has asthma and a pacemaker. That pacemaker might be responsible for the pulse of 70. I'm not sure. It seems a little low to me for someone having gone through that trauma. She's unrestrained. Holy cow, more serious than when restrained. You don't see a lot of unrestrained people anymore in crashes. Difficulty breathing. Is it trauma or asthma? Right? This is the way questions work. You put it out there. She has difficulty breathing. You put the asthma in, but is that what's causing it? She has a history of asthma. Well, what are the signs and symptoms of asthma? Think about it. When you take your stethoscope and you put it over the chest of a patient with asthma, and there's diminished lung sounds, that's not what you'd expect. You'd expect to hear wheezing. Right? That's the hallmark sign of asthma. There's no wheezing here. I'm not sure we're talking asthma. And the history of the pacemaker, well, maybe that explains her heart rate. Diminished lung sounds, well, she's got it doesn't say chest trauma in here, but I got to tell you, diminished lung sounds and bowel sounds in her left lung base. That means that some of her guts have been squished up into her chest cavity. The vital signs, I don't know. Vital signs aren't the smoking gun here. I think we have a certain amount of criticality here that might not be reflected in the vital signs. How do you put it all together, right? So what do we do? Do we administer oxygen? Do we assist her ventilations? Do we assist with the administration of her inhaler? Or do we wrap her chest with an elastic bandage? Well, hopefully you didn't choose wrap her chest with an elastic bandage. That would restrict breathing. That's not the answer. And I don't think that assisting her ventilations are necessary, right? She's complaining of difficulty breathing, so she's talking to you. And while she has diminished lung sounds and bowel sounds in her left base, her saturation of 96% doesn't look to me like respiratory failure. I'd want to watch her, but it's not failure right now. So we have assist with the administration of her inhaler or administer oxygen. There's no wheezes. There's no sign of bronchoconstriction. So in this, administering oxygen is the best choice. Now, some of you are saying, wait a minute, her saturation's 96. We don't give oxygen if it's above 94. Not necessarily true. She has diminished lung sounds and her guts have been squished up into her chest. That is the best one of all the choices there. We don't need to assist her ventilation. Not like we can push her guts back into her belly. She's not wheezing. We don't wrap her chest. Right? Remember that oxygen in that 94% rule is really good for heart attacks and strokes. But remember, though, that there are times that patients might be critical. They may have a lot of difficulty breathing. They may have really poor skin signs, or in this case, diminished lung sounds and protrusion of abdominal organs up into the chest cavity. Oxygen becomes the best choice of all those that are there. All right. Let's do another. We have two more to go. A 6-month-old female is cyanotic and slow to respond to stimuli. Her father tells you he found her this way on the floor and removed an empty balloon in her mouth. Her pupils are pinpoint. Her vital signs are pulse of 72 and a respiratory rate of 16. After you begin to ventilate her, you should. Okay, let's take a look and see what's important here. She's 6 months old and she's cyanotic and she is slow to respond. Yeah, not good. Empty balloon was in her mouth and her pupils are pinpoint. Vital signs, pulse of 72, respiratory rate of 16. We've seen this before just in this exercise, haven't we? That pulse is slow for a 6-month-old, as are the respirations. Now, after you begin to ventilate her, you should, right? After you begin to ventilate her. Now, you've done a treatment there already, okay? And you need to know that when you look at the choices because you've already done that. So she's 6 months old, right? She can't tell you what's wrong, and her pulse and respiratory rate are both slow. Okay, cyanosis is a late and ominous sign, really, for anybody when it comes right down to it. Slow to respond, it's like limp was in the prior question. Just lethargic is bad. The empty balloon. There's multiple potential meanings here. Many of you are probably thinking that was the baby choking? Was she hypoxic? Because kids can certainly get low pulse rates when they are hypoxic. But the pupils are pinpoint. Was that a heroin balloon? Just pausing there because some of you didn't think about that. All right. Vitals are slow for that age group. And after you begin to ventilate, we're saying, what's next after you've done that, right? So our choices: begin chest compressions, administer naloxone, assess her blood pressure, or ask her father to discard the balloon. Well, let's get rid of the ask her father to discard the balloon. Not only does that do nothing for a patient, a young patient that is in a critical condition, it may also get rid of the evidence of the heroin overdose that the 6-month-old had. And assessing her blood pressure on a 6-month-old, assessing her blood pressure is challenging anyways, and it's not going to get you anything. The two big choices are begin chest compressions or administer naloxone. So what this really comes down to is you recognizing two things in this question, right? One is that her pupils are pinpoint, and that makes you think heroin overdose. Now, when you get these little ones here, we ventilate them when their pulse is below 100, and we do compressions when their pulse is below 60. So that pulse of 72 doesn't indicate compression yet. So that really kind of knocks that out of the picture. So if you're looking at this and you didn't get the heroin part, you're thinking, if you know you shouldn't do compressions at 72, you should say administer naloxone. Why would I administer naloxone? If you go back to the question and see pinpoint pupils, you may have an aha moment that says, oh, now I understand why I should administer naloxone. And since you're ventilating her, the next step would be to administer naloxone. Correct answer? Choice B, naloxone. See how every part of these questions tells you something. You can't rush through these questions. If you're taking the EMT National Registry, you have a minimum of 70 questions. Now, 10 of those are going to be pilot questions and don't count. You don't know which ones they are. You have a potential to do 120 questions, but you have a minute per question because you get 2 hours. My belief is that if you read these and you take a minute, maybe even a little over a minute per question, not all of them, some you're going to look at them and say, oh, I know this one, that you might have the chance to do less questions because you're getting more right. Remember that the National Registry exam is adaptive. If you get questions right, it moves you to a more challenging question. Matter of fact, if you start getting weird or really hard questions, people tend to freak out. It's probably a good sign. All right, last question. Which of the following strategies should be used to make responding to 911 calls safer? Well, that's a pretty simple question, one sentence, but even now you still have to read it. You're going to go back, you're going to look at the choices, and you're going to say, what did I need to find out in this question? Well, we're looking at strategies and responding to 911 calls, and we have to make them safer. And they say, well, gee, it's a simple question. I really shouldn't need to do all that, but sometimes you do, right? Strategy. Every word makes a difference. They're looking for a strategy. You may see how that comes up later. Responding to 911 calls, right? This particular part, it's the responding part, right? Responding and safer, not faster, not more convenient, not more fun. What makes them safer? All right, now let's look at the choices. Use GPS mapping systems to determine the quickest route of travel, right? Well, remember we said not the fastest? Reduced following distance when using law enforcement escorts. Well, escorts are pretty dangerous in general. We generally try and avoid escorts. What happens is the police say, I'll escort you to the hospital. Follow me. And often they say, stay close. And you get really close. Well, the two things that may happen: one, if you're too close, the cop has to stop suddenly, hit the police car. Two, the police car goes through. People think that the emergency vehicle has gone. They can't tell your siren from his. And then traffic starts in the intersection and you get hit. So don't do escorts. When responding with other emergency vehicles, use multiple routes of travel. Well, that would just make you crash at the intersections. But minimizing the use of lights and siren responses would actually make it safer. Now, you may look at this and say, well, don't we have to use lights and siren responses? Actually, no. Lights and siren responses are more dangerous, and they don't save the time you think. They can cause additional stress for the patient. And lights and sirens are not always necessary, and it's more dangerous. But look at this. GPS mapping is faster. The next two really don't make anything safer. You could look at those and find them to say, oh, well, but minimizing the use of lights and siren responses most certainly will. So I hope that these questions helped you think about the amount of reading, time, concentration, and valuing of the individual words and concepts in a National Registry question that you need to succeed. So the path to success with LIMR education is three parts, and we believe in these very much. It's been a formula that has helped students succeed for a long time. The three components of this: first is content knowledge. In this session, you have and you will continue to learn not just about how to take a test, but we explain a question, we give you insights into pathophysiology and knowledge that you need not only to pass the test, but to work on the street as well. So this program is going to give you some of that content knowledge, and you should look at every question you take and say, did I know that? And if I didn't know something, put it on a list or write it down and be able to look it up and build that content knowledge. Now, on the other side of your screen, you'll see understanding the National Registry style. Those questions are written differently than your classroom questions, and that's kind of a bummer. I know that. But you got to know how the questions are written and how to read and value them, right? The first part of this presentation leads to what you see, what it means, is really designed to help you do that. But those two concrete things surround the one in the middle, mojo. You have to believe you can pass the exam to pass it. You have to believe that the work you did in class, the work you did at home, is getting you to the point you have to be. Now, I'm not so foolish to believe that everybody goes through EMT class and takes this seriously as they should. Some of you are probably here after one or two or more unsuccessful attempts at the National Registry, and that can affect your mojo. And you're probably at a point where you said, gee, maybe I should have done something differently in class, or I'm trying to figure out how to study now. Well, this presentation is going to get you to a point where you can work and get that mojo back. I can't flip a switch and do that for you. You have to work for it. But the concept of being able to feel like you've done the work, you feel like you've studied, you feel like you're prepared, we believe that makes a difference when you go into class. So we're going to get into now what we call the readiness assessment test. Now, this is part of research that I actually conducted in 2018. What we did is we took a large group of people, actually soldiers in the combat medic program in the Army, and we gave them a series of questions. And we said, can a small series of well-crafted questions predict whether a person passes or fails the National Registry? And it turns out that people that got a certain number of questions correct were more likely to pass the registry, and people who got a certain number or below were more likely to fail. And these questions test judgment. They're kind of like mini National Registry questions, but what they do is they don't so much test your ability to take a test, but to make the judgments that are required. A few seconds ago, I said, well, the National Registry's tests are different than class. Class sometimes tests recall and lower level cognitive things. When the National Registry asks you a question, and as we've seen already, they don't give you a lot of information, and you've got to put that together. So I'm going to go through these, and I'm going to give you a very brief scenario. And I want you to make a judgment. I want you to think about this. I want you to look at this. Remember, you can always pause this recording and think about it. Right? I'm just going to keep going and giving you these, and I have 12 of them. So let me show you how the first one goes. If my patient has a blood glucose of 64 and appears confused but conscious, I would. And now here's some choices. Administer oral glucose, look for the cause of the confusion, or monitor the patient in transport. Correct answer, administer oral glucose. Why? Because he's hypoglycemic, even though it's not a lot, and has an altered mental status. They're conscious, so you should be able to give the oral glucose without risk. Now, why is that the answer? Because monitoring the patient in transport leaves a treatable patient untreated. Well, that's not good. Looking for the cause of the confusion? Well, I think we can kind of see the cause of the confusion here, right? 64, you say, oh, that's only a little low, but it's still low. Now, the other thing about blood glucose is it can be a little bit relative. If their blood glucose is normally 250, 64 is real low. 100, well, it might be a little bit different. And everyone's response to hypoglycemia is different. I talked to people when the blood glucose was 25, and I've had people that were pretty gorked out, not an official clinical term, in the 60s. So look at this. If my patient has a hypoglycemic blood glucose and has an altered mental status, they need to get some glucose. So that's what we're doing here. And when you look at National Registry questions, this is just a snippet of the question, but it's testing almost your gut. It's testing your decision making to see if you can look at a small piece of information and make the right decision. Because ultimately, the National Registry doesn't give you tons of information. That's the other thing that happens in class. They have really long questions and all the information's there, and it's easy to make a decision. But when you get something like this, we're not just testing memory, we're testing judgment. If my patient has substernal chest discomfort with a cardiac history, I would administer oxygen, ask if he has nitroglycerin, or administer aspirin. All right, so substernal chest discomfort and a cardiac history says, okay, that's a cardiac cause. We have three choices. Well, this kind of tests how you've been taught a little bit. Remember, I told you we're going to give you content information here as well. The correct answer is administer aspirin. That's the first thing you do. You don't need vital signs. Heck, emergency medical dispatchers tell people to choose some aspirin. They don't have vital signs. It's not going to affect things hemodynamically. There's two reasons you don't give aspirin. Active GI bleeding and allergies, right? Now, oxygen. People don't routinely get oxygen anymore. This patient has substernal chest discomfort and a cardiac history. It doesn't say respiratory distress, doesn't give a saturation, and we don't automatically give oxygen. So should we ask if he has nitroglycerin? Sure. But after we give aspirin. Why? Aspirin prevents platelet aggregation. Okay? By eliminating platelet aggregation, what we're doing is we're keeping that clotting and clumping from happening, and we may be able to limit the extent of the heart problem. That's why administer aspirin is the correct answer and the best answer of those that are given. So if my patient is alert and sober, complaining of neck pain after a car crash, alert and sober. Not all of our patients are like that, but in this case, the patient's alert and sober, complaining of neck pain after a car crash, I would place him on the stretcher and transport, in a collar and on a backboard for transport, or in a collar and on the stretcher for transport. Now, what this question does is this says, have you been taught spinal motion restriction or spinal immobilization? The correct answer, the patient would be placed in a collar and on the stretcher for transport. We're not going to transport that patient on a backboard. It's uncomfortable. It causes pain. It's not necessary. The concept of spinal motion restriction says a collar and the stretcher keeps the spine from moving. It doesn't do any harm. It's the way we do it now. Now, he has neck pain, so he needs a collar. So just putting the patient on the stretcher is not right. But the second choice, in a collar and a backboard, that's not right either. So putting the patient in a collar and on the stretcher is called spinal motion restriction. And that is the way that we are handling a patient like this now. It's important that you know that. All right, next. If my patient is in respiratory failure, I would expect the blood to be at a normal pH, more acidic, or more basic. The correct answer, more acidic. When we're in respiratory failure, we're now not moving enough air to live and support what our body needs. We're going to have more anaerobic metabolism that occurs without oxygen. As a result of that, our blood is going to become more acidic, right? What does the body really need for metabolism, right? Well, we need fuel. We need oxygen and glucose. But in the mitochondria, for us to produce energy, we can get a little bit of energy without oxygen, but it creates acid, pyruvic acid, which turns to lactic acid, and that's not good. So if we add oxygen in at that part, we go through the process of the Krebs cycle, and we come up with a lot of energy and heat, water, and that's a beautiful thing. But without that oxygen, that pyruvic acid sticks around, becomes lactic acid. We become acidotic. Our blood becomes more acidic because of that anaerobic metabolism. The basics of pathophysiology, maybe you did it early in class. Maybe you talked about it in shock. A lot of classes don't give all the pathophysiology that's needed. But when we have anaerobic metabolism, we're going to have acid. It's important that we remember that. All right, let's do another one. If my patient is in respiratory failure and has severe bleeding, I would provide ventilations, open the airway, or control the bleeding. Now, I always laugh when I talk to my students about this. You get an experienced paramedic, my patient's got respiratory failure and has severe bleeding, and one of them is going to stop pretty soon, right? This is a pretty serious situation. So the question comes, what will kill the patient first? And the answer is severe bleeding. So we're going to control the bleeding. That the EMT and the AEMT and the paramedic have to be a thinking profession. You have to say, what's going to kill my patient first? Because that's what I'm going to handle first. Now, this is, of course, if you're on your own. You may not be on your own, so you can do two things at once. But if it's you, we're going to control the bleeding. Arterial bleeding can kill a patient actually in less 2 minutes. Smaller arteries, maybe 4 minutes. But we're talking about really having to get on this bleeding thing or the patient's going to die, right? Opening the airway, provide ventilations, of course we're going to do it. Remember that we used to talk about ABC, but now we have CAB, and that relates to a couple situations. First, that we check the pulse and do CPR if the patient's lifeless. but also see for circulation, the bleeding. If we have severe bleeding, we have to do that first. Why? Because it's going to kill the patient first. Now, I hope that you're getting where I want you to be in this. These are judgment calls, but these also give current theories in EMS and medicine and help you pick what the most important things are. These aren't full National Registry style questions like we saw before, but we're breaking down really important parts. So far, we've seen spinal motion restriction and bleeding control and hypoglycemia when it's on the borderline. We're now getting through and testing your judgment. If you're not doing well so far, right, and you said, I didn't know that we had to do spinal motion restriction, or I was told, you know things that you can look up and get better at. All right, so if my patient has facial asymmetry and slurred speech, I would administer oxygen, complete a secondary assessment on scene to determine the cause, or transport promptly. All right, so the patient has facial asymmetry and slurred speech. Those are 2 out of the 3 elements in the FAST exam, or the Cincinnati Pre-Hospital Stroke Scale. So you're thinking to yourself, this is probably a stroke. So if you're thinking it's probably a stroke, the best thing that we can do is get that patient in the ambulance and transport promptly. Why? Because if the hospital is going to use a clot-busting drug to try and open up that artery in the brain, then that's got to be done within a certain number of hours, a small number of hours. So a secondary assessment on scene to determine the cause, I think we're pretty close to the cause. Now, we'll check the blood glucose, we'll do other things as well, but if you're thinking this patient's having a stroke, your gut should say, it's time to scoot. It's time to get to the truck and get started. We'll do the rest en route. And oxygen. This came up before, right? Facial asymmetry and slurred speech. It doesn't say the patient has difficulty breathing. It doesn't say the patient has signs of shock. It has signs of a stroke. And we don't automatically give oxygen in those cases. We only do that if we believe there's hypoxia. Oxygen is a drug. And how do we give a drug? Well, we give a drug when we have an indication for it. And the indication for oxygen is hypoxia. We have no signs of that here. Your gut should say, ooh, that's a stroke. We should get off the scene and do anything else we have to do en route because the patient's going to need this time at the hospital. It's the best thing we can do is get them to the hospital. Next. If my patient is 36 weeks pregnant and is experiencing painless, bright red vaginal bleeding, holy cow. I would suspect premature labor, placenta previa, and placental abruption. Well, there's a couple ways that you can look at this. And remember what I said previously. There's 2 ways to get a question correct. One is to know the answer. The other is to know 2 of them aren't the answer. And premature labor and placental abruption both have pain. All right? Labor pains, right? Somebody has contractions, so that's not it. And placental abruption occurs sometimes traumatically, sometimes during delivery. And it's a premature separation of the placenta from the uterine wall, and that hurts. But placenta previa, a condition where the placenta implants over the opening to the cervix, as the baby gets larger and puts more pressure on that, we sometimes see painless, bright red vaginal bleeding. So see where we're getting here with a simple question. We've gone over some of this, some of the causes of 3rd trimester bleeding. And also, I hope that you listen to the way I work these things out in my head. Please don't ever look at this and say, oh, I have no idea, and then throw your hands up and just pick something on the National Registry. Never give up. Always just make the best choice you possibly can. It's painless, so we know it's not labor. Even from there, you've got a 50-50 chance. And that's the way it works. All right. If my patient has pressure building in the brain after a head injury, I would expect an elevated blood pressure, clear fluid coming from the ears, or an elevated pulse. Now, I'm really surprised sometimes how we don't know vital signs trends, or how maybe on the exam or right now you're trying to figure out what it all means, right? In this case, if my patient has pressure building in the brain after a head injury, I would expect to see an elevated blood pressure. And why is that? Because as pressure builds in my brain, it's more difficult for the body to perfuse it. And the blood pressure has to rise to be able to overcome the pressure in the brain and be able to get blood to the brain. Now, it's not unusual to see, 220 over 110 in someone who's got really serious pressure building inside their head. Remember, there's no room in there. The brain takes up all that space, and a relatively small amount of blood begins to really make a difference. Now, you won't see an elevated pulse. As a matter of fact, you'll see a decreased pulse. Cushing's triad says that you'll see an elevated blood pressure, a decreased pulse, and irregular respirations. Cushing's triad. Clear fluid coming from the ears could happen from a head injury, but not because of pressure building. It's from a type of skull fracture. So that could happen, but that's not the answer here, right? If my patient has pressure building in the brain and doesn't say skull fracture or anything else, elevated blood pressure is what you're going to see. Why? Because the body has to increase the blood pressure to be able to feed the brain. All right. If my patient is 8 months old, moving minimally, and has a sunken fontanelle, wow, pediatric, always good to have some pediatric in here, I would suspect child abuse, hypovolemia, or respiratory failure. Remember the pediatric assessment triangle: appearance, work of breathing, and circulation to the skin. So moving minimally is bad for an 8-month-old. What does the sunken fontanelle mean? Right up at the top of the head, that anterior fontanelle is still going to be open at this point. And if it's sunken, it generally means low volume, hypovolemia. Now, child abuse, let's say that we had a head injury and there was increasing pressure, that would actually bulge. It wouldn't be sunken. And respiratory failure isn't necessarily going to affect our hydration status. So an 8-month-old kid, he's not moving a lot, the fontanelle is sunken, that's low volume. As a matter of fact, dehydration in an 8-month-old can really sneak up. And what do? We ask the parents, how many diapers has the baby wet? Has the baby been feeding? A leading killer of kids around the world is diarrhea. From some of the intestinal diseases and parasites that happen in the world, diarrhea is enough to dehydrate a kid very seriously. So that sunken fontanelle is the clue there. Why? Because they have low volume. So if my patient isn't moving and doesn't appear to be breathing, I would open the airway, provide ventilations, or check the pulse. So this comes down to the CAB approach. The way the Heart Association once said this, and sometimes I teach my students, is if the patient appears lifeless, you go up to the patient and you look at them. And sometimes the patient's color is bad, they've been down for a while, and you look at them and in your heart you think, oh, I don't think they're breathing or have a pulse. They look really bad, right? But if they're not moving, they don't appear to be breathing, we go to the CAB approach, that lifelessness. So what do? CAB, we check the pulse. We don't open the airway, we don't provide ventilations. Since they appear to be dead, they have no moving. No eye moving, no finger moving, no sounds, no moaning. And as you come up, you're looking at the chest and thinking, yeah, I'm not sure they're breathing. What do? We check the pulse. Now we can check the respirations again at the same time. But this really tests your knowledge of heart association guidelines. And that's really important. A significant part of the National Registry is on cardiology and resuscitation. That includes, stroke as well. But by the old descriptions, that could be up to, 20% of the exam. And it's 1 or 2 chapters in your book. So it's important that you look at this and you know those heart association guidelines, rates and ratios for compressions, what to do if you have a baby or a neonate, how things are different, how to ventilate when you have an advanced airway in place or not during a code. Those things are all important and things that you need to know. So in this case, if they're not moving and don't appear to be breathing, C. In the CAB, we check the pulse. All right, our last one of this. If my patient has been in a car crash and has a blood pressure of 110/88, I would consider the patient to have possible internal injuries, consider this a normal finding, or believe this reading may be caused by anxiety after the crash. All right, look at this. You've got a car crash. Doesn't say anything about mechanism of injuries. Doesn't say anything about injury. All it has is a blood pressure. So what's this getting at? I'm looking to see if you can identify a narrowed pulse pressure. The pulse pressure is the difference between the systolic and the diastolic blood pressure. Now, in this case, it's 22. And normal pulse pressures should be 25% of the systolic or top number in the blood pressure. So in that case, we should be looking at 27, 28, and right now we're looking at 22. So you look at that and you say, if you just blow through a question and say 110/88, oh, those numbers are good. You miss the fact that the pulse pressure is narrowed. Let me just say this again so we're clear. We subtract the diastolic, the bottom number, from the systolic. And if the difference is small, it's called a narrowed pulse pressure. And that would be defined as less than 25% of the systolic blood pressure. Then that has the potential to be compensated shock. Now, why is that? Top number is the cardiac output. Patients bleed someplace. Cardiac output's dropping. The bottom number represents the vascular resistance or the tone in the blood vessels. The body's going to constrict blood vessels to make the container smaller and maintain our pressure. That drives the diastolic up a little bit. So the top and the bottom numbers get closer together. That's the body trying to compensate for shock. So right now you've got the numbers that all seem above. I'm doing air quotes here. You can't see normal, but the pulse pressure should be concerning. So we would say, I think that patient's got internal injury, certainly until proven otherwise, because it's not a normal pulse pressure, and anxiety wouldn't narrow the pulse pressure. It might make the numbers go up a little bit, but the pulse pressure would stay the same. All right, so we've gone through a bunch of these, and the research said that if you get 7 or more correct, you're more likely to pass the National Registry EMT exam than someone who got 6 or less correct. Now, I'm not saying you got to freak out if you got 6, but I'm saying that these are core elements. There are some people who got 6 and passed, and not as common, though. And the purpose of this was, now that I've told you this, I didn't want to tell you numbers before and freak you out. So you can go back and do this again or count them. But not only did we say that people who got 7 or more were more likely to pass the National Registry, we went over 12 very important concepts. Okay, so that's the benefit in itself. The number you got right might make you say, oh, I got to really study a lot more. And between these 12 concepts and between the what you see, what it means, I think that you've got a sense of what you may need to study more and what kind of help you need. I think this is a good time to talk about misconceptions and misinformation You may have picked up in class little bits of this we've talked about throughout our session, but I think it's worth noting a few things specifically. Now, you may have learned something in class that's different than I'm going to say now. I assure you that these are the most recent thinking, that this is the material that would be tested on the National Registry. And yes, there's times that educators aren't aware of changes or maybe kind of teach the old way. Everybody has something in their class that might not match the book, but let's make sure that we know some of the common misconceptions. The first, we don't immobilize patients anymore. We restrict their motion when we believe they have spinal injuries. Spinal immobilization was a barbaric practice. We put people on a rigid board and with a collar, and we'd strap them down and we'd transport them in an ambulance, which probably didn't have the best suspension anyways. And they get them to the hospital and they don't even know whether the pain they're feeling is from the backboard or from a back injury. That's not good. So instead now we do spinal motion restriction. Spinal motion restriction says, let's say somebody's standing outside their car after a crash and they go, yeah, my back hurts. You say, okay, don't move your neck or your spine. I'm going to put a collar on you. Then I'm going to have you just sit on my stretcher. Then I'm going to help guide you till you're lying down. We're going to put some straps across you. You put them on the stretcher. That spinal motion restriction is enough. Usually when people have pain in a part of their body, they don't want to move it. So the collar and the stretcher is fine. Now, if someone's in a car, you can spin them out onto the board. But when you get the board to the stretcher, you slide the patient off the backboard. We really don't transport on backboards at all. We just have to restrict motion. We overuse backboards and they cause pain. Spinal motion restriction. Now, some concepts of neonatal resuscitation. All right. If the pulse is below 100, we ventilate. And if the pulse is below 60, we do compressions. And this goes really for pediatric patients in general. All right. But picture you deliver the baby, you get the baby out. What do? Well, we got to dry it and warm it and stimulate it. And in the process of doing that, we take the seconds it takes to kind of get them settled. And we're going to look for a lot of things, motion and crying. But we're going to take our stethoscope and put it over their heart. It's the best way to get a pulse, especially the pediatric side of our scope. And if we listen to that pulse and we believe it's below 100, we ventilate. And if it's below 60, we do compressions. Now remember that kids respond to hypoxia with bradycardia. So if you've got a low pulse rate, sometimes a little bit of ventilation pinks them up and gets their pulse rate up, right? But in kids and in neonates, and remember, neonate is birth to 30 days. We often talk about around birth. And don't forget that the rate that we ventilate neonates at is 40 to 60, which is different than the pediatric ventilatory rate. Now, the part that goes for neonates, and we have a lot, this is probably one of the bigger misconceptions. When I do my study sessions, people say, I say, what do you do? They go, suction. I'm like, no, we don't suction newborns unless they're in distress. Even if there's meconium. Let's say you've got a baby has some meconium staining, but they're pink, or maybe they're pink in the core and their extremities are blue, but they're moving and they're crying, right? And their pulse is good. Suctioning causes hypoxia in these little ones. It's not benign. We don't just do it anymore. When do we suction? We suction if they're in distress, if we feel like there's a blockage, something that suction would fix. Routinely suctioning doesn't make a difference. And most hospitals now don't even have bulb syringes in their delivery carts anymore to prevent this routine suctioning that can cause hypoxia. All right, maybe the biggest one, which is still around after, I think it's been about 15 years, but we're still here, oxygen delivery. I still hear people say everybody gets oxygen, or, oxygen, we give it to everybody who needs it. Okay, you know what the indication for oxygen is? Hypoxia. Okay? Now, we wouldn't, sometimes we give oxygen because we think it'll help the patient make them feel better or calm them down, right? Imagine if we did that with other drugs. Let's say we gave an EpiPen. Oh, let's give another one. Why? Oh, it'll be better for them, right? You don't give them another EpiPen, but oxygen, we sometimes don't think of as a drug. It's like giving out candy or instant reassurance. I think sometimes it makes us feel better. So what I'm going to do is I'm going to show you here a flow chart Because here's the thing about the National Registry, and I do believe what's good in the field is good in the National Registry. But we're told sometimes that either if every patient who needs oxygen gets it, right? And we're also told that if the saturation is below 94, we give oxygen. If not, we don't. And that's not necessarily true either. Let me take you through this flow chart quickly, okay? Does the patient's saturation indicate hypoxia? Right? Is it below 94? All right, so now we'll come down to the yes side here, right? So will a nasal cannula get them between that 94 to 99% we want? And if the answer is yes, we give them a cannula, we're good. And if not, we can give a non-rebreather mask. Remember, we always ventilate people in failure. And then what do? We monitor the patient, okay? That's great. So if the patient's hypoxic, we're going to give them oxygen. This is not a bulletin to anyone, all right? But what about the patients who have good SATs but might still need oxygen? Well, let's come over to this side now. All right, is there other credible evidence of hypoxia, including anxiety? Do we have abnormal breath sounds? Or is the pulse oximeter reading unreliable? If that's the case, we can give some oxygen. Doesn't mean we can never give oxygen. If they seem like they're sick, right? And there's something, because anxiety can be a sign, symptom of hypoxia. We have breath sounds. We just still think they might be hypoxic. We're not saying it's absolute. In this case, maybe we will. But let's say they don't have that, and we come down to the no side. Does the patient appear to be in significant respiratory distress or have evidence of compensated or decompensated shock? If that's the case, yes, takes us back to giving oxygen. But if not, the patient doesn't need oxygen, right? Now, if you say the patient doesn't need oxygen, what are we saying? We're saying they're not hypoxic. And we're also saying that they don't have any other signs of this, no anxiety or other things, and they don't appear to be in respiratory distress. They don't have significant accessory muscle use. They don't look horrible, and it doesn't appear that they're in shock. Okay, in that case, no oxygen. And this is the way I want you to think on the street, and it's the same way I want you to think on the National Registry exam. Many times, people will use, even if you're watching this video, question comes up and you just go through, you just want to get the answers and get through it. But that's not really how learning works. The concept of reflection is you look at a question. Let's say we have questions on here. We have EMT pass, AEMT pass, paramedic pass, have outstanding questions. And I've got even some of my students. They read the question, they pick an answer, they got it wrong, they go, oh man, and they move on to the next one. But they haven't reflected on it. They haven't said, what did I miss in the question that would have helped me get it right? That's an important part of the National Registry, that reflection. So take the question. I actually recommend reading it twice. It's good habit to help get you in a good way to just go slow when you're on the National Registry. And then make a choice. Submit it, and you see a rational answer. And the rational answer, you read it and you go, all right, it looks like I missed, well, maybe you missed a narrowed pulse pressure. Maybe you missed the word shallow and you should have ventilated. Look back at the question and read it again and say, all right, let me read this again and see if I can figure out what I got wrong to be able to do that. That's how you learn to take a National Registry question. Just flying through test questions without any reflection or any learning doesn't help you as much as if you really try and figure this out. So, do you understand the clinical concepts and pathophysiology behind it? Did you read it slowly, understand what it's asking? Because we just want to start getting through these questions. But play the game. We play the game the way we practice. And if we practice reading questions well in our study apps, we're going to do better on the National Registry. This is serious stuff. And if you haven't been successful once or more times before, now is the time for you to do it right. It's the way I'm studying effective. When you have even today, as you listen to this and watch this video, were there things I talked about you didn't know? You should be writing those things down. Pulse pressure, chest injuries, wherever it was. Like, wow, I totally forgot about that stuff. Pregnancy complications, pediatrics. If there's things you didn't know, write them down and look them up. That's probably the best way to study. Now, I write a textbook. I write the emergency care EMT textbook. I love my textbook. I believe it gives you good information. But if you read it in class and you studied, I don't think reading it 3 more times is going to help. Now my book becomes a reference. When you write down things you didn't know, go back to the book, or maybe things you mixed up, go back to the book and get them right. And then finally, how will you know when you're ready? Well, I got a little bit of bad news for you. I'm not sure you ever really feel like you're ready. You're always going to want a little bit more study. But I will say there's a couple things I threw out here for you to think about. First of all, if you paid attention in class and you got good marks in class and you've done some preparation, maybe you're watching this video and you're thinking, I got a lot of those right. Well, it's time to take the exam. Because the second thing I want to tell you is the longer you wait, the more you forget, right? And we're afraid to sign up for the exam and take it because we're not ready. But as we let time go by, not only does it become more of a threat and a stress in our head, we really do forget. If you're taking a class that goes, August to December, you should be saying, okay, maybe I'll study over the holidays and I'm going to take it the first part of January. Or if you're taking a January to May class, you should be taking that earlier in the summer to get that done. Don't wait. You're never going to feel ready. But if you worked, you pay attention in class, you did well, and you're doing some review apps, and you're doing this video, it's time to sign up if you feel good about it. If not, don't waste time. Do good things and get into the National Registry. Now, the National Registry is big on doing new types of questions. Now, multiple response questions, when they were initially put on the exam, they were all pilot questions. They were questions that were being tested. That doesn't last forever. These questions are going to count. So they're appearing on the National Registry. They want more than one answer. They may give you, for example, 2 of 5. Now, there's no partial credit. If they want 2, you've got to get both of those, or else you get the question incorrect. So you look at these and you're thinking, okay, it's kind of like a giant true-false question, right? Let's put it up. In which of the following would you expect to see jugular venous distension? Choose 2. Okay. Well, I would look at this and say that we would want things that would cause obstructive shock, things that would cause obstruction in the chest, and probably not things that cause bleeding, because they tend to have normal to flat jugular veins. So ventricular rupture, not so much. Abdominal evisceration probably isn't going to cause pressure to keep blood so it can't get back into my chest. That's what it means. Those veins are distended because there's something blocking it from going back in the chest. A pneumothorax is going to collapse part of the lung, but not enough to cause that. What's going to do it? Cardiac tamponade and tension pneumothorax. So remember a couple things that I said, that you can look at each one alone and say, will this cause it? Yes or no. That's ultimately what the question is asking you. They don't build on each other. Just you've got to know these things. That cardiac tamponade, tension pneumothorax are really the 2 big things that cause obstructive shock. You should know that JVD means obstruction and that the other ones aren't going to do it. So you'll be told how many, 2 of 5. And you've got to choose the 2 that you believe are more likely to get you there. So let's do one more of these. Which of the following occurs during exhalation? Choose 2 of the following 5. Well, when we exhale, our chest chest wall collapses, our diaphragm rises back into the dome shape, and pressure increases to force air out of the chest. So, well, the pressure inside the chest rises is good. Diaphragm flattens, no, that rises. Intercostal muscles contract, no, that expands the chest. Air flows out of the chest, that's correct. And the systolic blood pressure drops slightly. No, that's actually during inhalation. So it looks like we're looking at A and D. All right. Using practice tests, boy, I tell you, sometimes people just, when you get a good app like our EMT pass, our AEMT pass, our paramedic pass, that have really challenging, very similar questions to the National Registry, you go through and take a question, you read the question, and then you pick something and you hit submit and you get it wrong, you go, oh man, and then you move on to the next question. And that's not the way it's supposed to work, right? So when we use practice tests, there's a few things I want you to do. I want you to use practice tests and have you actually pretend in your head that it's the National Registry. And why is that? Well, one, it'll make you less anxious when you get to the National Registry, but two, you'll know what to do when you get to the National Registry. The sports analogy is you play the game the way you practice. So here's what I would do. One, read the question carefully. Maybe read it twice. I mean, seriously. Read it twice. You have the time. And then choose an answer. Hit submit on your practice app. And if it's wrong, don't just go, oh, rats, or some other colorful term, and move on to the next question. Read the rationale. Read the rationale and say, okay, then go back and read the question and say, what did I miss when I read the question that would have helped me get it right? Because we've talked several times during this recorded session you're watching that said the National Registry questions are different than you get in class. Sometimes they're intimidating. Sometimes they're a different style than you had in your class. And we have to learn how to do those. This is one of the best ways that you can do it yourself. I mean, really, without me, figure out why. Sometimes we talked about pulse pressure. Well, gee, the pulse pressure is narrow. I didn't catch that. Maybe it's one word, shallow or sleepy. Maybe you missed a concept. The child was limp in the parent's arms, right? It's things you've seen here. Those things will help you if you go back and reflect on those, that you'll be able to figure it out better. And keep a piece of paper by you while you study. And while you take that out, while you take those questions, and use that paper to write down things that you need to study. That's how you should be doing it. Make a list, and when you're done taking your practice questions, you've got a list to go back in your book and refresh yourself on. That is vitally important.
Next section of our video on preparing for the National Registry involves the National Registry TEI questions. TEI stands for Technology Enhanced Items, and clinical judgment questions. It's our job to prepare you for the National Registry. When the National Registry added question styles, it was our job to be able to present these to you to help you succeed on all parts of the exam. So here we're going to talk about the new technology items and the clinical judgment questions. We'll answer your questions. We'll give you a detailed explanation and demonstration, not only on how the questions work, but how we want you to think and apply that information to be successful. So the question types that we're going to get for all levels. Now the exams are different. EMT is a different exam than AEMT and paramedic. There are questions that everyone are going to get. Multiple response items. They've been on the exam for a while. In those types of questions, you'll choose 2 of 5 or 3 of 6 choices. It's not just a one multiple choice anymore. Now you have to pick 2 or 3 out of a series. Now option boxes are check boxes. You're going to sort and organize or classify, categorize based on clicking on the screen. Now, drag and drop, we're going to move items into columns. These might be clinical. These might be operational. So a lot of things that the National Registry has done to be able to give you a list of things and have you move them into columns. Could be diagnosis. I'm going to show you those. And then finally, sequencing and build lists is where you put things in order or prioritize them. I'm going to show you one of these. I'm going to use an example of an anaphylactic reaction, but you might be required to put the steps of patient assessment in a certain order, or you may have to prioritize which symptoms are more significant and which symptoms are less significant in the patient presentation. Now, AEMT and paramedics, they have another type of questions. EMTs, you won't be getting these, and these are called clinical judgment scenarios. These are evolving scenarios, and there's multiple questions on these, 8, 10, 12 questions. And there's a lot of detail provided in these questions, from the weather to the distance to certain hospitals to the type of crew that you're presented with. And when the National Registry did away with the psychomotor exam, they wanted to have a sense that you'd still be able to put things in order, that you'd be able to develop priorities, that you'd be able to run a call, essentially. And these clinical judgment scenarios do that. They have you make clinical decisions, treatment decisions, prioritizing, clinical judgment, ultimately. And that's what they do. I'm going to show you these. I have a 10-question scenario I'm going to take you through. Now, before we get started in the video, I want to give you a couple general rules, things I want you to think about when you're taking these technology-enhanced items. When you have to pick 2 or 3 out of a list of 5 or 6, or if you're taking and you're putting things in order, the National Registry does not grant any partial credit. So if you get one part of it wrong, you get the entire question wrong. I don't want to freak you out, but I need to tell you that. Like any time you take a National Registry question, I think it's even more important now to read the questions carefully, to make sure you know what they want. When you do these technology enhanced items, checking boxes, drag and drop, make sure you know what they're asking. Now, these questions can ask you almost anything. The National Registry is known for crafting amazing questions. And they have a way of asking questions that can sometimes seem a little foreign. But be prepared to get into a certain amount of clinical depth. I'm going to show you that. I'm going to give you an example of DKA versus hyperglycemic hyperosmolar syndrome, something EMTs and paramedics need to know. And you're going to be asked questions in a little bit more detail. So what do I think? I think we need to up our game. I think teachers have to teach well, and I think you as a student have to study well to really be able to go through these. And you're going to see the depth of the questions they ask in this new style. But you know what? Finally, the functionality is easy and intuitive. If you've used a computer, if you've ordered from a menu, if you've been on a dating app, right? We swipe, we drag and drop, we do certain things. So the technology isn't really the issue here. Reading the question and making sure you know your stuff, that's the issue. Don't let these technology enhanced items get into your head. Don't let them be the bad guy. Don't make them into an artificial barrier. Quite frankly, people tend to like these questions better, especially the clinical judgment scenarios for AEMTs and paramedics. I think there's a certain amount of intuitiveness to this, and I think it tests well. All right, I want to stop talking. You know what? Let's get into some practice. All right, so let's look at these questions. Let's actually dig into these technology enhanced items. First example we see on the screen is called an option box. I want you to think of this as kind of like a matching question. If you had a piece of paper in front of you and you had to either draw a line from one side to the other to make things match or write a letter down of what matched, that's what we're talking about here. So in this question, for each of the following, determine whether the patient is more likely to have diabetic ketoacidosis or hyperglycemic hyperosmolar syndrome. Now, this is clearly a paramedic question, but quite frankly, could be an EMT question as well. EMTs need to know this and get into some depth on this. So let's take a look. Now, a type 2 diabetic is more likely to have hyperglycemic hyperosmolar syndrome. There's a little bit of insulin there, probably some insulin resistance. So we're going to choose that one. Rapid deep breaths. Now, what's interesting about this, that's diabetic ketoacidosis. That's Kussmaul's respirations or Kussmaul's breathing. Now, the National Registry might say rapid deep breaths. And the reason it says that is maybe Kussmaul's would give it away. Sometimes we use the terminology, sometimes we don't. You know that the rapid deep breaths, trying to blow off some of the acids from diabetic ketoacidosis. Hyperglycemic hyperosmolar syndrome generally has a higher blood glucose. Diabetic ketoacidosis is somewhat limiting as far as how high the blood glucose will get. The fruity breath odor, those are the ketones from ketoacidosis. And this one, diabetic ketoacidosis, is more likely to happen in the type 1 diabetic. Now, you've got type 2 up here. We chose this one, so we're going here. Now, you will submit this question on the National Registry. When you use our products, we of course will give you an answer. We'll show you whether it's right or not. In this case, you see that it's right. So you'll be able to check as you go through and do these and get a rationale with our products. The National Registry won't give you whether you're right or wrong. You're going to move on, and that's it. So it's important that you are happy that you can just choose your answers and then move on. Once you move on, let it go. Now, like I said, there's no partial credit for these items, and that's one of the challenges we have. Now, this is a drag and drop question. Similar approach to that matching phenomenon. Differentiate the following findings into categories of signs or symptoms. Now, there's 3 in each category. That helps you figure it out. If you're not sure about one of them, but you're sure about the others, you know where the others go. The National Registry usually gives you this information. There's no attempt to trick you. So signs are things that we can see, and symptoms are things the patient tells us about, right? So if we look at this, now terminology is always a thing on the National Registry. A lot of people say, I don't know the terms, and Limmer Education doesn't shy on those terms for you. Tinnitus is ringing of the ears. Right? We can't see that. That's something a patient tells us about. That's a symptom. Abdominal distension. All right, I also look at all the ones I choices there. There's abdominal discomfort as well. Well, distension, I can see. And if you know one that you're sure about, discomfort is a symptom they're going to tell me about. So now I'm going to say, well, I can see JVD. That's a sign. I can see pedal edema. Now you might look at frequent urination. Don't get too deep in your head. Frequent urination, okay, maybe they're peeing on your stretcher. In that case, I guess it could be a sign. But look, we've already got 3 signs and there's 3 in each category. If we don't see the urination, that's a sign the patient tells you about frequent urination or polyuria. Now in the National Registry, you would just submit this. I'll submit the answer here. We'll of course see that we have correct answers here, and we will move on to the next question. In this case, we have a multiple response item. We choose 2 of the following 5. Usually there are 3 wrong answers. So you might get 2 of 5 or 3 of 6. Now what I want you to do is I want you to look at this kind of like a multiple part true-false question. Which of the following would occur as the result of an anaphylactic reaction? Which of the following would occur as the result of an anaphylactic reaction? Choose 2 of the following 5. Maybe some of them you don't know. Sacral edema, would I see that, true or false? Sacrum, that's my lower back. I'm going to let that one go. Decreased vascular tone. Decreased tone means my blood vessels get bigger. I like that one. Increased stroke volume, that would increase my cardiac output. Yeah, I'm not thinking that's the answer there. Jugular venous distension, I see in tension pneumothorax, tamponade, right heart failure. Ooh, increased capillary permeability. So it gives me that angioedema, makes my face swell. I'm gonna look really quickly here. I've got 2 of 5, no partial credit, but my blood vessels get bigger, my capillaries become more permeable or leaky. no JVD, no increased stroke volume, no sacral edema. This is how I'm going to go through and answer these questions. And there, boom, we did it. Let's take a look at another one. Now we have a drag and drop. Now, not everything is going to be a question that involves, oh, we got a lot of choices here. Let's read this one first, then we'll move it. We have a lot of choices. We're going to drag them, it looks like, into inhalation and exhalation. Determine whether the actions below are part of inhalation or exhalation. Drag and drop each to the appropriate category. There are 3 in each category. All right, that's really important. Pay attention. So, inhalation or exhalation? All right, so the diaphragm is dome-shaped when it relaxes. When it contracts, it flattens. So I'm going to go to exhalation. Intercostal muscles relax. Well, relaxing sounds like exhalation because inhalation is work. Pressure in the chest decreases. And the pressure is a tough one. The diaphragm flattens. Well, that's inhalation. I know that one. I'm showing you how I want you to think about this. Oh, muscles contract. That would be inhalation. Now, pressure in the chest exceeds the outside pressure. Well, that's what forces air out. I'm going to say that's exhalation over here. Oop, I can drop that over into here. There we go. And pressure in the chest decreases. Well, when it decreases compared to outside air, air rushes in. So I'm going to say that's inhalation. All right, now I've sorted these. What happens if I don't like one? Don't freak out about it. You can drag it back out and rearrange it. That's okay. Don't think because you drag it over that you're going to be stuck. You're not. You have the ability to think about this. All right, so we're going to submit our answer here. And we did good again. So we're giving you a little bit of tutoring on different types of physiology and pathophysiology as we go here. All right. Oh, these are my favorite. I'm a clinical guy. I'm kind of a clinical nerd when it comes to these things. 23-year-old was found by bystanders on the street. He arrived to find the patient sitting up and appearing disoriented. There's pale, moist skin and an elevated pulse. As you speak to the patient, they become more confused. Choose the condition the patient presents with and your treatment. Read that well. Make sure you're clear before you go into this. You've got to pick a condition. Let me move this up here a little bit. And a treatment. I'm going to go with the condition first. Pale, moist skin really is making me think hypoglycemia. Hypoglycemia used to be called insulin shock because it looks like shock. Generalized seizure. They become more confused. Now, generalized seizure, they get better as they come out of the post-ictal state. An opioid overdose, there's no indication of, respiratory rate or depth or anything in here. And that gradually going downhill and being disoriented really says to me hypoglycemia. Now, since I've chosen that as the condition, I look at my treatments. Do I transport? Do I administer glucose or administer naloxone? A lot of people freak out about this. They become more confused. People say, I can't give glucose because they're confused. Actually, an indication for glucose, oral glucose in this case we're talking about, is altered mental status. What we're really concerned about is their gag reflex. Can they swallow and control their airway? Since I picked hypoglycemia, I'm going to administer glucose as my treatment. So now my most likely condition is hypoglycemia, and the appropriate treatment is administer glucose. All right, I feel comfortable with that. That's how I want you to think when you go to the National Registry. I feel comfortable, I'm ready to move on. Don't agonize, but don't rush. You have time to do this. I'm going to submit my answer. Again, we can look and see whether we're correct or not. In ours, the National Registry, of course, will just move on. All right, and then finally, a build list. A build list. Now, I chose this one because it's pathophysiology. It's good review for us to go through. Place the sequence of events in the order they would occur in a patient experiencing anaphylaxis. Wow. So basically it's saying, how does anaphylaxis work? In what order am I going to see these things? All right. Now, you're going to be given a piece of paper. If you'd feel more comfortable, you can write this down on that piece of paper or that dry erase board. Or remember, you can drag and drop these things in, but if you don't like the way it's going, you can move them out, you can move them around. Don't worry about this. This technology is not scary, but it really does test the material you're supposed to know. This is what we're supposed to do as EMTs, AEMTs, and paramedics. So now I think person is sensitized to a substance. Okay, which means we're exposed to it the first time. And the body then says, whoa, this is a foreign substance. If I see this again, I'm gonna almost kill myself with anaphylaxis. So then the person's exposed to the substance again. Okay, good. So now we don't have all the steps, but the person's exposed to the substance again. Now that is the antigen, and that goes in and attaches to the antibody. There we go. And then, the granulation of mast cells occurs. Mast cells, basophils, and that releases a lot of bad stuff. That's going here. All right. Then blood vessels dilate, right? Our vascular tone, we lose our vascular tone. We have hives and wheezing. Well, it sounds like the last step to me. All right, so now I'm going to check it before I submit it. I get sensitized to something and I'm exposed again. That antigen, that substance, attaches to an antibody and it degranulates or opens up those cells, and all these chemical mediators are released. Histamine, prostaglandins, leukotrienes are released. Blood vessels dilate, hives occur, and wheezing begins. I think that's my plan. There we go. We did it, and we are correct. So that's called a build list. If you're comfortable working it out on the screen, you can drag and drop and move things around. It's a piece of cake. But in any of these questions, don't be bashful about using the paper or the dry erase board they give you to help work these things out, right? So the questions that we talked about, starting at the beginning, were the option box, right? We have some drag and drops that we did. We have the build lists in this, and we've gone through these things you're going to see. These questions, again, will be seen on all levels of exams, EMT, AEMT, and paramedic, and they will count on all those levels. Now, some of them could be pilot questions, of course. When we see this, remember that you've got to get them all right. There's no partial credit. Now, if you're an EMT, you can stop in this video right now, because the one I'm going to show you next are performance scenarios, but these will only be given to candidates taking an advanced life support exam, the AEMT or the paramedic. You're welcome to stay. You'll learn something from this about National Registry questions, and maybe you want to go on and be an AEMT and paramedic, so you're welcome. But I want you to know in this, EMTs will not get these next questions that we're going to talk about. The ones you just saw are all fair game, right? Multiple response, option boxes, the drag and drop, the build list, they're all for everyone. This next one, the performance scenario, is when we have multiple questions all tied to a scenario. In this case, I'm going to do a 10-question scenario. I think we may see these ranging from 8 questions to 12 questions, depending on how they go. They can be on a variety of topics, medical, trauma, and they may have operation sections, questions, pharmacology, all kinds of things in here. One of the things that's very different with these questions is that you get a lot of information, but you're always able to reference it. And when they give you this information, it's because they're probably going to use it at some point, right? All right, so this is a performance scenario for AEMTs and paramedics. You're dispatched for a 33-year-old patient who has a large laceration of the right leg from an accident involving a grinder. Dispatch reports the patient's alone and unable to provide an exact address. Time of the call is 15:12, 3:12 in the afternoon, 6-minute response time. EMT partner, BLS fire apparatus is dispatched along with you. You're a paramedic. Dispatch says there's a general residential neighborhood where the call originated from. I guess they're still trying to figure out where it is. Ambient temperature is 58 degrees. Community hospital is 15 minutes away. Level 2 trauma center is 45 minutes away. You're saying to yourself, why are they giving me all that? Well, they're probably going to ask you about some of these things. This will come into play. Now, what we do is we give you the question and new information in bold text because it builds as you go along. What additional information should you ask dispatch to determine before your arrival? Patient's medical history. I don't know. What medications do they take? I mean, emergency medical dispatchers are awesome. However, we don't often get into the history and meds. What's the exact location of the patient at the residence? Does the patient have any weapons at the residence? I'm going to find, because what should you ask dispatch about? Dispatch may ask about weapons. It's a grinder thing. No meds. I'm going to say, what's the exact location of the patient at the residence? Because this person's bleeding. Okay, we're giving you feedback, and we'll give you some rationale answer here. The patient's exact location, because they're by themselves, there'll be nobody to direct you. See how that comes together? The patient's alone and unable to provide an exact address. That plays into this answer. So the most important information is the patient's exact location. All right, we're going to go on to the next question, and it's going to give us a little bit more information. As you pull up to the scene, the garage door is open. You see the patient sitting alone on the floor in a garage workshop. You and your partner gather your equipment and head into the garage. The patient's holding a blood-soaked rag to the right inner thigh, and there's a large pool of blood under the leg. Right now, you got to picture this. This is a scenario. The patient's alert and they're sluggish responding. All right, so they can answer you. They're going to be alert and oriented, but they're slow. Looks severely pale, cool, clammy skin, shocky. Think they're going to pass out. Okay, that's a clue. They're cutting a metal pipe with a grinder. It slipped and hit their leg. Select the 3 answer options you should immediately do. Okay, multiple response. What should I do immediately? Administer oxygen. Well, the patient's probably going to get oxygen, but is it immediately? You got to read what you're asked. Remove the rag to expose the wound. And if you're going to stop bleeding, I think that's a good one. Cut away clothing covering the right thigh. I'm liking that one. I'm going to look on, provide spinal motion restriction. No. Place the patient supine. If he feels like he's going to pass out, that's a good one. Open the airway and look for obstruction. Patient's responding. I'm going to go supine. I'm going to cut away the clothing. Correct. So see how immediately, sure, you're going to give some oxygen, right? Maybe you'll open the airway, but right now he's responsive. That's not what you're going to do immediately. You're going to get to that bleeding. And since they're going to pass out, see how that information fits in? That helps us say, put them in a supine position, because then they'll be less likely to pass out, right? And if we give you a rationale so you can help understand these things better, the registry's not going to do that. All right, new information. The wound is 3 centimeters distal to the inguinal fold, and it's 4 centimeters wide diagonally across the inner thigh. Now, an inch is about 2.5 centimeters. So that's only an inch below the inguinal fold, the crease in the leg. My first thing is, how am I going to fit a tourniquet there? I'm not sure. Full thickness, gaping, massive, steady flow of blood is coming from the wound. You can see a large lacerated vessel bleeding. In controlling the hemorrhage and managing the wound, you should instruct your partner to cover the wound and apply downward pressure with a palm. Apply a tourniquet. I don't know if a tourniquet's going to fit there. Place their gloved hand into the wound and apply fingertip pressure directly to the lacerated vessel. That I like. Find the femoral pulse in the groin. We don't do pressure points anymore. I feel pretty comfortable that I'm going to find that bleeder and I'm going to do it. Correct. Right? Yeah, diffuse pressure, that palm of the hand. When you can get in there, you should get in there. All right, we're going to continue on. People, when they do these questions, people actually feel like these are easier than the traditional National Registry questions. You've got 10 questions in this scenario. If you got 10 random National Registry questions, sometimes they come up and they're very bizarre. Getting 10 in order, the way we practiced in our skills lab, the way we do things in clinicals, many people actually like these better than the 10 random questions they would have gotten. Do not make these questions, whether it's the technology enhanced items or these performance scenarios, the bad guys, right? Don't do that. People sometimes like these better. And this is giving you a really good example of what they're like. Right? Get new information here. You can read back on the old stuff. We can see we're on scene here still because we have pre-scene, on scene, and post-scene. En route, on scene, post-scene. After your partner applies focused pressure, you continue the primary assessment and find the airway is open. Respirations are rapid with adequate chest rise. It's telling you there's no failure. And the radial pulse is absent, but a rapid carotid pulse is palpated. All right, shock. Your partner tightly packs the wound with a hemostatic agent. While your partner does that, select the two answer options you should immediately do if time permits before transport. All right, big 14 gauge catheter I'm going to want, but do I do that before transport or would I do that in the truck? Administer oxygen. That's a contender. 12 lead. It's a younger person with trauma, probably not. Administer a bolus, so I'm going to need an IV for that. Cover the patient with a blanket. Boy, maintaining heat is so important in shock. And what can I do quickly here that's going to make a difference? I could put some oxygen on. All right, that's correct. So hypothermia worsens shock. It's part of the trauma triad of death. And administering oxygen, it doesn't even matter what the person's pulse ox is when they've been bleeding like that, right? It's fair game to give oxygen. And it doesn't say non-rebreather, nasal cannula, just oxygen. Is oxygen beneficial in this profound shock state? Yeah, I think so. All right, you getting this? You seeing the way you feel, seeing the way you think, how the information continues as you go along? Fire department's on scene. They assist you in loading the patient onto the stretcher and into the ambulance, and then assist with transport to the hospital. So it sounds like you've got people. During transport to the hospital, we get some vital signs. Pulse of 132, respiratory of 28, 72 over 58. SpO2 is unobtainable, not a surprise. Your partner tells you, despite holding direct pressure, the wound is bleeding through the dressings. You should immediately, right? Wound is bleeding through the dressings. So first, do we give a fluid bolus? Doesn't stop bleeding. It might help us with the blood pressure, but it doesn't stop bleeding. We gotta stop that bleeding. Apply a cold compress and hard palm pressure. That's not gonna be big enough. Pack the wound with more hemostatic dressings and press harder, or remove the dressing and repack the wound with a new hemostatic dressing. We're talking about hemostatics. We got the stuff in there and it's soaked and it's not stopping the bleeding. It's time for a new dressing. Remove and repack the wound. If the wound can't be controlled with direct pressure or gauze and direct pressure, you move to a tourniquet. If you can't do that, I probably would have gone to a tourniquet right away, but because of the wound's location, you can't apply a tourniquet. So see how all the information from earlier starts to come back to you, and you can always look back on that. Cold pack and heel of the hand pressure or the palm pressure isn't going to be enough either. We need to really hit this hard. Our questions are going on and see how they flow. Now, in this case, at the paramedic level, during your reassessment of the patient, hemostasis has occurred. The patient is confused and responds sluggishly. Their skin is white and cold. Their current vital signs, 148 for the pulse, 26 now and shallow for the respirations. Blood pressures continue to go down, still can't get an SpO2. Here's the ECG. Wow. Based on the patient's current hemodynamic status, select the 3 answer options you should do. Well, I am I'm going to get IV access. I'm in the truck now. And I'm going to give a fluid bolus. I might end up giving more fluid boluses, but we'll see. Cardioverting him. See what this is. If somebody looks at that rapid rate and says, oh, I got a cardiovert, I'm going to get that rate down. How do you get that rate down? Well, you try and deal with the shock, right? I'm not going to cardiovert him, and I'm not going to give lactated ringers at a keep open rate. That's not right. I'm going to continue to keep them warm. There we go. While en route, your priority is to keep the patient warm, get an IV access, and administer a fluid bolus. Now, I can't say for sure, but as I'm doing this, there's probably going to be more questions on this. We're not near the end. I put this in, we've only had 6 questions so far. I know we got 4 to go, so we know there's going to be more questions probably about this treatment that we're giving, and we're in the post-scene phase now. We're going to the hospital. During your reassessment of the patient, hemostasis has occurred. All right, we got that, the bleeding stopped. Why is normal saline often used in fluid administration to hypovolemic patients? Right, it can carry oxygen to the cells. No. Its tonicity is equal to that of the interstitial fluid, allowing it to stay in the vascular space for a longer period. Right, that seems like a true statement. Now we know isotonic solutions don't really stay that long, but longer period than it would be hypo or hypertonic. Has a lower tonicity, quickly leaves vascular space. Nope, that's not it. Higher to no, it's isotonic. All right, so what's our choice? We're going to pick this one. And we're going to move on. Correct. Normal saline is isotonic. See how this question goes through and takes all that stuff that you learn and puts it in, all the things that you learn, the things that you do, and then put some knowledge questions in here as well, a little pharmacology perhaps in here. All right, so we go on to the next question. Which of the following hemodynamic findings indicate you have achieved your initial fluid administration goals? Mean arterial pressure of 90, that's up there. Systolic blood pressure of 90, that's got potential. Mean arterial pressure of 50 is too low, and the systolic blood pressure of 110 is too high, unless we're thinking about a head injury when we might want to try and get a little bit higher to perfuse. I want to say 90, and I'm correct in this. I should get one wrong just so you can see what it looks like, but I want to give you good examples as we go through this. All right, we go on to the next question. Remember when you click next, that you've got to let the prior questions go. You got to clear your head. All right, in this question, we've got the same information again, the same vitals. If you suspected this patient also had a spinal cord injury and was also hypovolemic, you should. Well, starting at the bottom, I don't want to restrict fluid administration. 75 millimeters of mercury, is that going to be enough to really get the perfusion I want? Continue crystallite fluid administration until the patient becomes alert. Somebody this sick is not going to become alert from a crystallite solution. But I think I really want to get that mean arterial pressure up. There we go. We don't want to have hypotension, so we want to be able to move up. The neurological outcome is better with the head and spine if we can get a little bit higher blood pressure. I think it's important to remember that. All right, let's look at the next question. All right, so now we have a TEI question which can blend in here relatively well. During your reassessment of the patient, hemostasis has occurred. The patient is confused, responds sluggishly, skin is white and cold. We got that. Same vitals. What is the likely physiological effect of hypothermia on this patient? All right, we got some pathophysiology here, a shock question. And what treatment should you ensure to reduce the likelihood of it occurring? The effect, well, we don't get more energy. I don't think we decrease production of free radicals. Decreased production of fibrin molecules will reduce clotting, right? So we don't increase ATP. We probably have too many free radicals. Let's say that physiological effect of this, of hypothermia, is that we're going to have coagulopathies. The fibrin's going to be an issue. And what's the treatment? We don't want cooled fluids. Fresh frozen plasma room temperature, I'm not sure we always have that in the truck, but warmed crystalloid fluids might help that hypothermia. Let's see where we are. And we're correct. Okay, so that was the last question here. Now, when you go through our products, you can finish, and we're going to say, all right, 10 of 10 on this. We did well. Let's just talk about a couple take-home points about these clinical judgment scenarios. One, they're reasonable. Don't be afraid of them. Right? Don't do that. Walk through this like you're going through. Think of any of the scenarios you've been given in class, some of the case studies you've read, things like that. You've had some pharmacology tested here, some pathophysiology tested here, some trauma care tested here. These are things that are very much what an AEMT or paramedic have been trained on. It goes in a logical order. Some of the questions are more challenging than others, but I continue to believe this is better than getting 10 random bizarre questions. And most people I've talked to have enjoyed these more. Now, on individual questions, like the drag and drops and the multiple response, you have to get everything right in those questions for them to count correct. However, you don't have to get every question in this scenario correct. If there's 10 questions here and you got 8 or 9, that may very well work towards a passing score. I think it's important that you do this. I think it's always important to take your time and read. The one thing I will say is that you're given a lot of information, but you can see how they always pick back at that information, and the information that you were given in the beginning of this scenario will be available throughout the scenario anytime you want to look back at it. So what we've done is we've given an overview of the different types of National Registry technology enhanced items that EMTs, AEMTs, and paramedics will get. Everybody will get those. And the technology isn't scary. The knowledge you have to put in there, yeah, you've got to do some studying for those, but you can do this. And for our ALS people, our AEMTs and paramedics, we went through this performance scenario, sometimes called a clinical judgment scenario. And the chances are is that you're going to get somewhere 2, 3, possibly more. But most people I've talked to are getting a couple, 2, 3 of these. So now you know what this is like. Limmer Education products have these types of questions in, the clinical judgment and all those TEIs. Get to it, get practicing, and pass that test. Dan Limmer signing off. Thanks for watching.